Good afternoon to all of you and welcome to the post-lunch session of day one in the major hall, Hall A Convention Hall. In this session on pediatric ophthalmology, we have got along with me Dr. Sasanamam, Chief Instructor. We have got three pediatric ophthalmologists, Dr. Rashmi Bhaskar from Chaitanya, Trivandrum, Dr. Chaitanya, our warrior from Chaitanya, Tiruvalla and Kottayam, and Dr. Vaishakhi Prasannan, pediatric ophthalmologist at Chaitanya, Kochi. And our star guest today is Dr. Shankar, who is Professor of Pediatrics and HOD of Medical Genetics at the SAT Hospital, Government Medical College, Trivandrum. And we are fortunate to have him as our guest speaker. Actually, he is the Scientific Committee Chairman of the Kerala chapter of Indian Academy of Pediatrics, and they are having their annual conference on the same days. And actually, their dates got postponed. But anyway, because of his commitment to me and also to his love of genetics being spread across, he has come all the way. So many thanks to, and I welcome you, Dr. Shankar, and thanks on behalf of the KSOS and on our behalf, hearty welcome to you. And though he is Professor of Pediatrics, he is this genetics, DM genetics, and the department of genetics makes him all pervasive. He can attend a conference of any medical specialties, irrespective of whether it is medicine or surgery. So the title is Pediatric Eyes Looking Beyond Vision. In 5 minutes, I'll just give a bird's eye view of what we are going to discuss in this session. Normally as ophthalmologists or for any doctors for that matter, when we look at, say, a child brought to us, talking about pediatric ophthalmology, a child brought to us with defective vision, we assess the visual acuity of the child. We assess the signs and symptoms, ask the parents, ask the child if the child is old enough. And we plan the necessary investigations which can be done in our clinic, in our room, and in our adjacent rooms in our clinic. And we treat accordingly. But there are certain situations, most of the cases which come to us can be either surgically or medically assessed and treated in our purview. But there are certain situations where you have to look beyond this. If we look at a child brought to us with a defective vision and the routine evaluation doesn't point to a diagnosis. It's not our routine refractive errors or not an uncomplicated strabismus or a congenital cataract which and the child being brought to us. So there is a defective vision in this child. There is a subtle posterior segment pathology. So we have to do more of electrophysiological studies to find out what this child is having. We see a child with defective vision. We see a subtle pallor, or we don't find anything at all, but there is a defective vision. So we need a medical neurology opinion, and we need a lot of imaging studies. A child brought to us with a congenital cataract or a retinal pathology or optic nerve pathology, we want to look at the genetics. So all these things will be covered in this 4 talks which ensue. And another thing is we have recognized CVI, cortical visual impairment, as a clinical entity, and a lot of work has been done in the recent years. In the last 1 decade probably, a lot of work and improvements have happened in recognizing as well as treating. When we say treating, there are various modalities. So we know now at the present juncture, we know how to manage CVA in a better way than we used to in the previous years, but there is a long way to go. So that also we will discuss here. And if you look at the inherited genetic disorders, we have got a bunch of diseases in the eye, especially in the posterior segment, which fall in this group, and a lot of work is going on. And we have got in the last decade, we have been successful in coming out with an FDA-approved therapy for RP with RP65 mediated inherited retinal disease, Luxturna. And so this RP65 gene mediated disease, when we talk about it, it's not only, when we talk about RP, it's a small segment of RP. And also Leber's congenital amaurosis also can be RPE65 gene mediated. And genetics, like Shankar will tell you, there is an areas, the amount of genetics which we used to study earlier, no, it has, the advancement which has happened has leaps and bounds. So the genomic analysis, mapping of genes and the variants that contribute to, in our situation, inherited retinal disorders, stem cell therapies as regenerative treatment, social disorders, which we see experimental things in a lot of retinal pathologies, and neuroprotection and regeneration, like cell programming or cell reprogramming for that matter. Because recently I was reading that when we talk about cell reprogramming, we all know that Muller cells conventionally, when we used to study, we thought Muller cells have only a supportive function, nutritive function, homeostasis of the retina. But we have found that in cases of necessity, you can reprogram the Muller cells to become neural or photoreceptor components. So that is cell reprogramming. And in gene therapy, we have got like gene editing, genetic engineering tools, gene editing. Like we edit a video, if you have a mutation which produces a particular disease, we can edit that portion of the gene which has undergone mutation and replace that by a healthy gene, which will code for the right protein. So we have got the genetic engineering tools, and we have got pharmacogenomics. Patient care by tailoring the drug therapy to suit a particular individual's genetic profile. So lot of things are coming on. So thank you, and we will have the other speakers speaking to you on all this in the coming 40 minutes. So over to the second speaker, Dr. Chaitanya.
Good afternoon to one and all. I would like to express my thanks to Dr. Sahasnama sir and KSOS for making me part of this IC. I am going to discuss the role of imaging in unexplained defective vision in children. When a child presents to our clinic with complaints of defective vision, we usually think the causes to be like either a refractive error related defective vision, or any associated problems due to amblyopia, or any strabismus or even microtropia related defective vision, or any media opacity from cornea up to the retinal layers, or any visible syndromes or associated with ocular injury, or any posterior segment pathology. When we examine the child and do the needful examination, if there is no refractive error or no features related to amblyopia or strabismus, media is clear, no visible syndromes, no ocular injury or posterior segment pathology, we will be puzzled, and here comes unexplained defective vision. So we need to dig more. What is the cause for unexplained defective vision? Nothing is seen during the initial examination. It may be due to some hidden optic nerve issues, or any causes due to cerebral visual impairment, or some intracranial pathologies not yet identified. Sometimes maybe a migraine with aura, or any genetic or nutritional problem, or sometimes rarely non-organic causes like malingering. So during this time, we need to do a much more detailed history and examination. A thorough detailed history including the antenatal, postnatal and the further developmental history. Also family history, whether any associated defective vision or any related disorders in the family, and we need a little more detailed evaluation from the routine procedures. We need a full cycloplegic refraction and the orthoptic examination, color vision, OCT imaging of macula, RNFL and GCC, fundus photography, electrophysiology and imaging will be needed in these cases. What is the role of imaging in an unexplained defective vision in a child? Unexplained defective vision with any RAPD or sluggish pupil, any newer onset nystagmus, especially vertical nystagmus, any nerve palsies or newer onset squint, or any optic disc changes like disc edema, pallor or atrophy, or systemic features of raised ICT or any other systemic features suggesting neuroimaging, we need to proceed with imaging. MRI brain with contrast or CT orbit in suspecting orbital pathologies, and selected cases we may need MR angiogram or venogram and digital subtraction angiography. We will discuss few cases. A 9-year-old girl present to OPD with defective vision for 1 year. She was evaluated in multiple places and during CAMS also. Her uncorrected visual acuity was 6/18, not improving to any refractive error with glasses. Anterior segment, pupil and orthoptic evaluation, everything normal. Cycloplegic refraction also within normal limit. Only positive finding was bilateral temporal pallor. She was not able to do a reliable HFA. OCT, RNFL and GCC reveal temporal fiber loss. We want to rule out intracranial space occupying lesion. So did the brain, MRI brain with contrast, it turned out to be normal. When the patient came with the MRI report along with father, we re-evaluated the history. Father also gave the same history of defective vision at the age of 18 years, diagnosed when he was going for a army recruitment. Wife was normal, mother of the child is normal, and the elder brother is also normal. Only father and the daughter is affected, possibly a familial optic atrophy, advised genetic evaluation. Another case, a 10-year-old boy, teacher noticed defective vision. All normal development, siblings and parents were normal. Uncorrected visual acuity was 6/36, not improving with glasses. Fundus, subtle macular RP change is there. So possible diagnosis of early chondrodystrophy or early Stargardt's was made. Macula showed severely thinned out with EZ loss, highly suspicious of Stargardt's. But due to profound visual loss, that is 6/36, we advise ERG turn out to be normal. To rule out any brain-related pathology, MRI was done. It was also normal, so now he is undergoing genetic testing. Another case, 8-year-old boy came with complaints of defective vision, not able to copy letters. His preterm, he was a preterm long neonatal ICU with developmental delay. His vision was not improving beyond 6/12. Microcephaly was there. He is mildly hyperactive. All the examination was normal except for a minimal temporal pallor. On further reviewing all medical records, neonatal period reveal periventricular leukomalacia changes. Probably a CV-related visual impairment was diagnosed. Advise MRI brain in this case to know what is the extent of PVL changes at present. Here the MRI was done to know what is the extent of PVL changes and to prognosticate the vision improvement. Another case was a case of 12-year-old boy came with complaints of headache and defective vision. He was obese, not using glasses. He was having a significant refractive error, not improving beyond 6/24 in right eye and 6/18. He was not using glasses regularly. So, fundus, there is a mild hyperemic disc with blurring of disc margin. Possibly there is a, it can be related to either compound myopic astigmatism with amblyopia, but due to this fundus changes and obese nature, we want to rule out intracranial pathology, advise brain imaging. Another case, a 11-year-old girl came for glasses. She was using glasses for the last 4 years, but not improving beyond 6/9. Here we advise MRI because she was having a persistent giddiness. MRI was advised from ENT side and turned out to be an astrocytoma was there. So role of imaging is for diagnosis, to rule out intracranial pathology and to prognosticate vision improvement with glasses based on structural damage and as a part of follow-up in unexplained defective vision. Thank you.
So thank you, Chaitanya. And the next speaker is Dr. Vaishahi Prasannan. She's talking on the role of electrophysiology. Role of electrophysiology in unexplained visual loss in children.
Okay, hi everybody. Let me start by thanking for this opportunity. We'll discuss about role of electrophysiology in unexplained visual loss in children. These are objective and non-invasive technique for evaluation of visual function and to differentiate between disorders of retina, optic nerve and visual pathway. The advantage is that it's possible from early days of life and requires no subjective input from the patient. We'll discuss about different type of electroretinography, electrooculography and visual evoked potential. A full field ERG records the generalized electrical response of the retina and helps in distinguishing whether the rod or cone system is more affected or whether the dysfunction appears at the level of photoreceptors or after that. Multifocal ERG assesses the function of multiple discrete area of the central retina, mainly from the cone pathway and commonly used in cases of hydroxychloroquine toxicity, retinitis pigmentosa and Stargardt's disease. Pattern ERG is particularly important. It records the function within the macular region and it emerges largely from the ganglion cells, that is the N95 component, with contributions from photoreceptors and bipolar cells, that is P50 component, and helps in identifying any cases of retinal ganglion cell dysfunction. Pattern ERG in combination with other recording can help in finding out the site of dysfunction. That is a normal pattern ERG with normal pattern VEP is suggestive of non-organic cause. If the pattern ERG is normal or only N95 component is abnormal along with an abnormal VEP, it's suggestive of optic nerve dysfunction. An abnormal pattern ERG with a normal full field ERG is suggestive of maculopathy. If both are abnormal, it's generalized retinal dysfunction. Electrooculography records the functional integrity of retinal pigment epithelium and its interaction with outer retina, classically used in confirmation of Best's disease, and an ardent ratio of less than 1.65 is considered to be subnormal. Visual evoked potential assesses the conduction along the optic nerve and the functional integrity of the visual pathway up to primary visual cortex. It can be recorded even in preterm infants starting at 24 weeks, and if we want to localize the impairment along visual pathway, we need multi-channel VEP with additional electrodes. There are three types of VEP. A pattern reversal VEP is most preferred because it gives a less variable waveform and timing. Pattern onset offset VEP is used in case of malingering and in patients with nystagmus because it's less sensitive to poor fixation, eye movement or deliberate defocus. In case of poor vision or poor cooperation, we use a flash VEP. Coming to applications of VEP in predicting the visual acuity, which is empirically done by determining the smallest pattern size that elicits a just identifiable VEP. In case of amblyopia, we get a diminished or absent VEP in cases of smaller pattern. In children with visual impairment, VEP is either unrecordable or recordable only to a larger pattern or flash stimuli, and thus help in ruling out malingering. In case of diseases of anterior segment or ocular media like congenital cataract or corneal opacity, a flash VEP should be done to rule out severe macular or optic nerve lesions to prognosticate the eye before planning for surgery. In case of visual pathway lesions, VEP helps in detecting a subclinical dysfunction and establishing degree of the functional loss or to monitor any progression or improvement in the disease. Coming to delayed visual maturation, this condition is characterized by infant appearing to be behaviorally blind at a young age in which the child doesn't fix and follow with no ocular or CNS abnormality which contributes to the visual loss is found out and usually recovers by around 5 months. If the condition is associated with seizure or mental retardation or perinatal insult, it can take up to 1 year or more to recover, but it gradually improves. In such cases, both flash and pattern VRP are present and normal when compared to age-matched control. Though some children might show abnormal VEP, but it gradually improves. In case of CVI, a normal flash ERG is seen with abnormal flash VEP. In case of acute cortical blindness, this flash VEP should be done, which helps in predicting the prognosis of the disease. It also helps in monitoring patients who are at risk of visual complications from disease or therapeutic intervention, differentiating between visual inattention in a child from abnormal vision, differentiating between static and progressive encephalopathies. Coming to inherited retinal disorders, it can be either stationary or progressive as shown in the slide. In these cases, ERG is particularly important because it has both diagnostic and prognostic value, and it should be correlated with the fundus finding and other investigations like OCT as and when required. In many cases of inherited retinal disorders, the fundus can be absolutely normal, as in case of congenital stationary night blindness or achromatopsia, or in early cases of Leber's congenital amaurosis or Stargardt's dystrophy, which are commonly seen. So even when nothing looks wrong, an ERG should be done, which can give a clue. In case of congenital stationary night blindness, an electronegative ERG is seen with a large A wave with an absent B wave. As we see here, fundus albipunctatus, which is a subtype of congenital stationary night blindness, is characterized by delayed dark adaptation. Here, ERG shows abnormal rod response, but usually get normalizes after a period of adaptation, as we see the lower waveform. In case of rod monochromatism, absent cone response is seen, but rod response will be present. In case of S-clone monochromatism, normal blue cone and normal rod response are seen. In case of retinitis pigmentosa, usually both A wave and B wave are diminished, but the amplitude of fulfilled ERG is proportional to the area of functional retina which is present in such patient. Leber's congenital amaurosis contributes to about 15% of congenital blindness. Here, electrophysiology shows an undetectable flash ERG in early age with a variable flash VEP. In Stargardt's disease, in early stages, the full field ERG appears to be normal, but pattern ERG usually appears to be abnormal or indistinguishable. But in case of advanced stages, in full field ERG will also be abnormal with an abnormal rod and cone response. In case of Best disease, EOG is the test of choice, and usually EOG shows an lower Ardens ratio, usually less than 1.5. Coming to another use, this electrophysiology can also be used in predicting the visual field in children, especially in small children or children who are having intellectual disability, in which testing visual field might be challenging. Thank you. Okay.
So thank you, Dr. Vaishakhi. And next speaker is Dr. Rashmi Bhaskar. She is talking on CVI.
Good afternoon. My topic is cerebral visual impairment with visual acuity 6/6. Is it normal? So we'll see a case scenario. A 9-year-old male child was referred to me by a developmental pediatrician as poor performance in school. Eye checkup done earlier was normal. Vision was 6/6 recorded. Fundus and external eye was normal. But she felt that there was something wrong with his visual response and came for a second opinion. When we took a detailed history, there was a history of hypoglycemia on the second day and history of NICU admission, mild developmental delay, poor performance in school, and mother complains that he bumps into objects while walking and he has difficulty to walk in uneven ground. External eye was normal, but fundus showed a mild temporal pallor. So we ordered for an MRI and it came as a hypoxic ischemic changes with occipital lobe gliosis, and his field was like this. He had a field defect, especially more in the inferior part. So what are we dealing with? So cerebral visual impairment has become a major cause for visual impairment in children. And in simple terms, we say that brain is not able to process what the child is seeing. And it can range from low functioning to high functioning. This is a child with a history of neonatal seizures and not very difficult to diagnose because he has a poor visual response and he doesn't respond even to lighter toys in dark light, and head control is also not attained. So this is a low functioning CVI. Now we will be discussing about the high functioning cerebral visual impairment. Why is it underdiagnosed or missed? Vision is not just acuity of vision. In high functioning CVI, they have almost normal or a near normal visual acuity, but they experience high level visual processing deficit. So lack of understanding of a child's difficulties will make it difficult to diagnose, and it will be misunderstood as a learning disorder, behavior disturbance, or an autistic behavior. So what is higher function visual deficit? From the occipital lobe to posterior parietal lobe goes the dorsal stream. And when anything happens in this stream, that will result in motion deficit, inability to see in crowd, poor spatial awareness, and inaccurate reading. And the ventral stream, which connects occipital lobe to the temporal lobe, is involved in visual memory, face, and object recognition. So we'll see how a child with CVI see. They can have a blurred vision, difficulty in recognizing face, tubular vision, inferior field defect, and difficulty in seeing moving objects. The cognitive dysfunction they suffer include optic ataxia, that is, when they see a thing, they will have to move and take it, but that will not be possible. Simultaneagnosia, difficulty to identify multiple objects at the same time. Difficulty in seeing in a crowded place. And difficulty in using multiple senses at the same time. When you are talking to him, he will be looking away. And when you want to speak, both visual and auditory won't come together for him. How to diagnose this? History. A proper history taking is very, very important tool because all these children will have some reason for brain injury. A clinical examination will be usually normal except for optic atrophy in some cases and some refractive error, strabismus or accommodation anomalies. Radiology, as Dr. Chaitanya has extensively told, can support our diagnosis. A normal vision and MRI no longer excludes the diagnosis of a cerebral visual impairment. A detailed history can be taken from the questionnaire regarding any insult in the neonatal period, postnatal or infantile period. And a detailed questionnaire which is developed by Professor Gordon Dutton, this is what we follow. It includes a lot of questions related to each of the difficulties that the child is having. We'll go through a few. If the parents reports of a visual behavior like child trips over the toys in ground, they have difficulty walking downstairs, difficulty climbing up the stairs, they'll be comfortable but they won't slide down, trip at the edge of pavement, all this indicate that the child may have a lower field defect. Other questions like reading difficulty, whether they find difficult to find toy from a toy box, difficulty in identifying the family members, change in behavior in a crowded place, difficulty in identifying shape. So how will you evaluate this? You don't need any sophisticated instruments. You need just few toys like things like balls. They ask them to separate it with colors, ask them to identify it. You have Leah's mailbox or puzzle box. They can identify the shape and size. And a Vikas app developed by the Mindtree and the Aravind, that is a very good tool. From that, we will be able to diagnose any visual abnormality behaviors, recognition of shape, and they give training also in that. This is a child doing the Leah's mailbox and Vikas app he is trying to do. Training also gives him same. You have to go with the child and see how he walks in a place where there is a small toys are laying in the ground, how he walks downstairs, how he is reading. All this will help to come to a diagnosis. This is a 4-year-old preterm child with developmental delay. Leah's box he is able to puzzle, he is able to do, but when it comes to a little more complicated things, he is not able to do it properly. This child with history of seizures, he is having an optic ataxia. He is able to see he want to pick the torch, but he finds it difficult to do. The test for simultaneagnosia, you can either use the Ishihara chart. They will be identifying the dots, but they won't be able to read the number. And they will be identifying the small t's, but they will not be able to identify the H made with that T. MRI shows the PVL changes is the most common finding that you will see. Other findings like occipital gliosis and a diffusion-based imaging will show the ventral as well as a dorsal streams defect. Coming to the management strategies. The basic treatment of CVI is training. What works for one child may not work for others. You prioritize the findings in them and implement 1 or 2 at a time. For example, if they have a difficulty walking downstairs, highlight the edges like we have done in our hospital, use bright light, minimize wall decoration. At the level of eye level, you can place something that is catchy for them, keep the floor surface clear, ask them to hold the elbow of the parent so that they will be able to know the difference in the floor space. For learning difficulties, you can highlight the numbers like this, use 3D tools, and you can make windows so that will be highlighted. You have to reduce the clutter and highlight the objects. Suppose a child is having a difficulty in catching ball. It's not because he is lazy, because he's not able to see a fast-moving object. You train them with balloons, which are slow-moving, or ball with sounds and lighted. And you have to reduce the clutter if they have a difficulty in finding objects. And in the top of a slide, they have difficulty sliding down. Start with smaller slides, gain confidence in them, give them verbal reminders to tilt their head so that they will be able to enjoy the park. If they have reading and writing difficulty, use finger to tracking. Slanting reader can be used where there is a lower field defect. Use typoscope and present material in small sections. So what is our role as ophthalmologists? A high degree of suspicion should be there if any neurological insult is there. Manage the coexisting ocular condition, understand the need and visual problem of each child, observe, spend time with them. If you are in a busy OP, call them another day when you are relatively free. It will take around 45 minutes to 1 hour to evaluate and give the report to them. Counsel the parents, then for the compensatory strategies and the environmental adaptation they have to take in school as well as at home. Work in team with the educational and therapeutic team. So it's basically a multidisciplinary team approach. You have to work along with the pediatrician, the neurologist, therapist, and most important, parents, because they are the best therapists for the child. Train your child to use vision in a meaningful way. Thank you.
So, and thank you, Dr. Rashmi. And now we are moving on to genetics. And Dr. Shankar, HOD and Professor Medical Genetics will be talking to us on genetic evaluation and pediatric ophthalmology. Over to you, Shankar.
Good afternoon all. At the outset, I thank my teachers, Sanam sir, other faculty and this KSOS for giving me the opportunity to talk in this august audience on genetic evaluation of in a ophthalmology case, especially pediatric ophthalmology. So what are the learning objectives? What I am expecting in this 15 minutes, not to learn the entire genetics, which I think it is definitely it's not possible. Just to understand the genetic counseling is important for any clinician, including an ophthalmologist, in some situations where they will come to you, how to go about. Then importance of definitive diagnosis in the affected person. Without that, a child or a father is blind. Just we cannot counsel them properly. We want to know what is a definitive diagnosis at the genetic point, which I will illustrate in 2 or 3 cases. And what are the points to be discussed during genetic counseling scenarios. And finally, 1 or 2 sentences on recent advances in gene therapy, which we are not routinely doing it, but it is the things which is going to come in next 5 to 10 years. So what is actually a genetic counseling, which everybody should practice? It is just a communication process to inform the family at risk of occurrence or recurrence of a genetic disease, a person about diagnosis, natural cause, treatment and its outcome, risk of recurrence, ways to prevent the recurrence, etc. And for properly doing this genetic counseling, because as an ophthalmologist, the couple may coming to you or saying that both of us are blind. What is the chance of developing the same problem in the child? At least you should have some idea how I will go about it. So you should know that what is the cause of the blindness is we have to identify. At the genetic level we have to identify. So, or they will come with a genetic report. At least you should be able to read what is the report, how to do that. So during this, to provide accurate information regarding the disease, natural history of the disease and how it occurs, etc. There are so many things, just like any other disease, family history, pedigree analysis, detailed history, gathering information, physical examination, reviewing the latest literature, etc., etc. But most important, crucial thing which I think the today new generation doctors should learn is the appropriate diagnosis of genetic test. Because these company people or the lab people will say that you can do microarray, you can do exome sequencing, whole exome, whole genome, everything can be done, which is costing fundas cost of 20,000, 30,000, 40,000. But actually it is useful or not, and how to read it, that everybody should understand. So there are so many genetic tests are there. Even 15, 20 years back, we cannot have this much genetic testings are not available. But now we are having from karyotype, FISH, microarray, optical genome mapping, newer tests are there, then RFLP, TP-PCR, invasion. Don't learn all those things, just to understand that there are various types of genetic tests are there. But most of the time, nowadays, we are using the next generation sequencing, panel testing, clinical exome, or whole exome. It is just for an introduction, where I will go to some of the case scenarios. Even though it's a pediatric ophthalmology, I've taken some of the couples also, because that is a common thing which will come for genetic counseling. Because they want to prevent the disease in the fetus itself. I think it is more than pediatric ophthalmology. A non-consanguineously married couple came for preconception counseling in view of both the partners or the history of visual impairment. So both of them are having visual impairment, and they had a history of spontaneous abortion, and they are very much worried that what about their child's, whether they will have. So most important thing is you should have a detailed evaluation including genetic testing in the both couples, both persons. So in the husband, it's a 31-year-old male born of non-consanguineous marriage. Presented with, I have seen the previous history and everything I have taken, reports I have seen. It's a bilateral congenital cataract, and his sibling is also similarly affected, which I have shown in the last pedigree. Whereas the girl, the wife, 31-year-old, non-consanguineous marriage. She had a bilateral retinoblastoma, detected at 3 months and 4 years of age respectively. Surgical intervention was done. There is a family history of cancer in father who diagnosed with myeloma. So actually both are two different conditions. We have to tackle this in two different ways. Directly we cannot say. Retinoblastoma is one thing, congenital cataract is different thing. So retinoblastoma is one of the important conditions where genetic testing will help you a lot. Because retinoblastoma is a condition, is a hereditary cancer prone disease where it is autosomally dominantly inherited. One mutation will be inherited through the germline and second mutation will have in the eye which causes the disease. That is called a Knutson's two-hit hypothesis. That is, one is mutation is inherited and another mutation comes in the tumor. So basically it is a in the tissue level, it is an autosomal recessive disease. That is, both the genes will be mutated, but it's an autosomal dominant inherited disease. If the mother, if wife is identified with the mutation in the germline, there is 50% chance that the offspring will get that mutation. And if they got the mutation, they have got a high chance to develop retinoblastoma or other diseases, other tumors like osteosarcoma, rhabdomyosarcoma, etc. So definitely retinoblastoma has to be genetically, testing has to be done. So in all patients it is there. Basically there is a phenotype-genotype correlation is there. Whenever you are having a multifocal bilateral retinoblastoma, it is almost 100% chance that there will be a germline mutations will be there. Whereas if it is a unilateral, unifocal retinoblastoma, there is only 15 to 20% chance to get the germline mutation. So definitely in bilateral diseases, early diseases, multifocal diseases, invariably genetic testing is mandatory to do. So next thing is RB1 gene. What are the mutations? There are different types of mutations are there. It is not a single point mutations. It can have a deletion also is possible. So sequence analysis alone is not possible. You have to do MLPA also to look for what type of deletion they are having. And if you identify the positivity, for example, in another case, I have shown this case, we have got another case where they are actually from Thrissur. First baby is having a retinoblastoma followed by osteosarcoma. And then only they came, the RCC people have referred, we have done the mutation, it is RB1 gene mutation positive. Younger child is 3 months only, so far there is no retinoblastoma, but is RB1 gene positive. So that child needs regular cancer surveillance. You have to have every 3 to 4 weeks, age 6 months, every 2 months from 6 months to 3 years, and every 3 to 6 months from 3 to 7 years. So regular follow-up surveillance. So this also can be, we can tell them if you properly genetic testing is done. Coming to the husband situation, congenital cataract, it is not like retinoblastoma where single gene. There is only have to only RB1 gene, not mutation. Whereas congenital cataract, it can be a non-genetic also. Intrauterine infections, galactosemia, hypocalcemia, diabetes, so many conditions can produce cataract. Isolated cataract can be a syndromic cause like Zellweger, Lowy, Stickler, RCDP, myotonic dystrophy, etc. Or it can be an autosomal dominant X-linked recessive. So many genes are known for this condition. So here if you go to the OMIUM, that is for PGs, if you want to know anything about the genetics, you go to www.omium.org, you put the congenital cataract, you will get all conditions where cataract is there. So here it is, you can see that there is 244 entries are there for congenital cataract. That means there is 244 genes, 244 loci is there for congenital cataract. It is humanly impossible to look for one gene to next gene to second gene. So that is why previously we cannot do that. But now with the advent of whole genome sequencing or whole exome sequencing by next generation sequencing, we can do multiple parallel sequencing of the entire genome to look for all these genes affected or not. So here we have done the genetic testing. Husband, you can see that is congenital cataract 18, autosomal recessive, 2 mutations we have identified. We will call it as a compound heterozygous mutations. Both are pathogenic variants. And his brother is also affected with the congenital cataract 18. And wife, RB1 gene, it is a 3' splice site mutation, hereditary retinoblastoma autosomal dominant. So here we can confidently say that cataract you don't have to bother because it is an autosomal recessive disease and wife is not a carrier of that gene. So 100% of the children will get one of the variant and they will be carriers of the variants, but they will not have any congenital cataract. But retinoblastoma, there is 50% chance that offspring will have that gene and there is a chance of developing the tumor. If they want, they can do prenatal diagnosis. If it is affected, if they want, they can opt for termination or those type of things. So this much perfect prenatal diagnosis can be done only if you do the genetic testing. So in counseling session, we will tell all those things. And another scenario, similarly, another couple came, it is a night blindness, and diagnosis is retinitis pigmentosa. But retinitis pigmentosa or inherited retinal disease is much more complicated, because too much complicated genetic disease, so much research is going on, because it is having locus heterogeneity, allelic heterogeneity and allelic disorders. That means there are more than 100 loci with same type of retinitis pigmentosa, and in same gene, different types of mutations can cause different type of disease. In the same gene, sometimes it can produce autosomal dominant disease, sometimes it can cause a autosomal recessive disease, and same gene, sometimes it can even cause a severe macular dystrophy also. So different types of complicated genetic inheritance is explained for retinitis pigmentosa, but here also genetic testing is mandatory to look for which is the genetic disease. Autosomal dominant, recessive, X-linked, all types of inheritance is available, and this is the percentage. So preferably we will use to the panel testing of multiple genes by next generation sequencing to look for any gene is involved or not. In this patient we have done, but you see, interesting thing is that person is getting two genes. One is CRB1, which is homozygous, likely pathogenic, retinitis pigmentosa 12 autosomal recessive. Another is PROM1, heterozygous, likely pathogenic, macular dystrophy. But I think, I have discussed with one of my friends also, they have told me you can differentiate with the phenotype. So here deep phenotyping is very important, because whether it's macula is paired or not, it is more fitting into the second condition or more fitting into first condition. Maybe an ophthalmologist help is definitely needed to tell that which is the more significant, because in which both is pathogenic variant we got. And this is one of the literature I have seen to see that. When I have got, I'm very happy to say that if you see the ophthalmologic genetics literature, there are so many Indian literature is there. So much Indian literature. So I have put only Indian literature in this presentation, because there are so many studies are there. This is one of the largest study from Shankar Nethralaya, where they have done around 250 patients with the retinitis pigmentosa, and because our population and Western population will be a little bit different, percentage will be different. So USHR2 is one of the commonest gene, CRMK is one of the commonest gene, our CRB1 is 6%, PROM1 7%. So both is present in our population. So definitely it is there, and it is different types of mutations, missense, nonsense, frame shift, all these things are reported. And why it is important? Because rate of progression based on the genotype is different. So if you see the USHR, we know that it is a little bit later onset, slowly progressive. And some of the conditions like RP65, RP, both types are there. Some of the genes are very severe progression is also there. And this article ends with, these are the, in their literature, these are the common genes which is having a rapid progression, and these are the genes PRF, PF1, PRPH, USHR2, etc. are the slowly progression. But the last sentence they have told, it is still very uncommon in India due to financial constraints as well as the unfamiliarity of the treating ophthalmologist with the genomic diagnostics. But I think it is absolutely, it is not financial restraints, because now the NGS cost, we are doing it only for 7,500, which I don't think it is not at all expensive. And we are doing more than 20, 30, 40 cases per month for various conditions, not ophthalmology, various conditions. Everybody is accepting. It is not very expensive. 7,500, I don't think it is very expensive. For this much information, you will get it. So we should routinely do the genetic testing for inherited retinal dystrophies. So last two simple cases, for completion's sake, it is one another case with the congenital Leber's congenital amaurosis, where we got RPE65 as the mutation. And you know what is the importance of RPE65, because since molecular pathology we know there are so many gene therapies coming for so many retinal diseases. And one of the important thing which is already in phase 3 study, phase 3 or it already is FDA approved, is Leber's congenital amaurosis, Luxturna, which is also available in India also by the Novartis, which is actually we have to give the subretinal injection and considered to be the therapy of it. And last case, it's a 1-year-old male child born of non-consanguineous marriage, presented with the clinical indication of failure to thrive, global developmental delay and hypotonia, ophthalmic evaluation, bilateral cataract, biochemical evaluation shows proximal renal tubular acidosis. So congenital cataract may be syndromic also. So here just I want to show you in the simple congenital cataract, we got 234 entries. 234 entries. But if you put congenital cataract with renal tubular acidosis, there is only 4 entries. So that is the importance of literature search, especially juniors. When you are going to the OMIUM or somewhere, specific diagnosis you will get if you put the proper things. Because these are not expert system, these are all systems for experts. You don't feel that all these AI just give you the diagnosis. AI, we should train it properly, we should ask it properly. Everybody knows, ChatGPT is also like that. So if you put it correctly, these 2 diagnoses, this child is having a heart signs, renal tubular acidosis and this. And why I have put this case is, this is the most interesting case for me as a pediatrician, but I put it last because probably these syndromes you may not be interested. But this type of syndromes, multidisciplinary approach is very important. Ophthalmologist, pediatrician, nephrologist, developmental stimulation, pediatric surgeon, etc. Everybody should combine together to do this. Here also genetic counseling can be done, carrier status in the mother. And this is the gene review. Whenever you are having some genetic disease, you can go to the gene review, which is actually a textbook of genetics. You will get all information regarding any genetic conditions in gene review, www.genereview.org. So take home message is importance of appropriate genetic testing and genetic counseling in ophthalmic disorders with genetic etiology should be a practice in day-to-day practice today, so that we can do a lot in counseling, prenatal diagnosis and definitive testing. And definitive diagnosis is very important, and anticipatory management we can do, prognostication we can do, and recent development of gene therapy, which should be the boom in era next 5 to 10 years. Importance of deep phenotyping and literature search in diagnostic pathway, both are important. Even though this is there, deep phenotyping, detailed examination is very important. Multidisciplinary care is important in patient management. So always we should collaborate and we should work together to get these patients benefited. Thank you very much for patient listening.
One or two queries. Regarding therapy for along with this evaluation and the genetic counseling, what are the in RP for a small segment? As of now, we have gotten treatment to offer. Other than in ophthalmology, are there any recent developments where genetic therapy helps in treatment other than diagnosis, prenatal maybe, because prenatal diagnosis helps in the appropriate way this is managed. Otherwise, in other segments of pediatric, pediatrics.
Okay, lot of innovative therapies are coming. Actually, one thing is our enzyme replacement therapy. So we are giving for lysosomal storage disorder, more than 20-40 disorders are there. Around 10 conditions we are having lysosomal storage disorders, where we are regularly giving enzymes like Gaucher disease, Pompe disease, etc. Similarly, we are having lot of innovative molecular therapies, like in plexiform neurofibroma, we are giving selmutinib. Selmutinib is a MEK inhibitor. Similarly, targeted molecular therapies, we are having so many therapies are there. This is coming one by one. In cancers is there. Then if you come to gene therapy, around 40 gene therapy molecules are FDA approved. 40. And one of this is Lextana. In spinal muscular atrophy, we are having ASO, nusinersen. Risdiplam is a molecular therapy. Then for achondroplasia, this vosaritide is there. DMD, there are so many antisense oligonucleotides coming. Cystic fibrosis, ivacaftor, that is I told. Because in 2004-07, I have completed my DM. At that time, even we are presenting the seminar as a hype or hope. But now in last 5 years, from 2017-18, after this Moderna vaccine, because Moderna mRNA vaccine, lot of mRNA molecules are coming. Lumisarin for primary hyperoxaluria is there. Cystinosis, a mRNA molecule is there. Then for so many conditions, hepatic porphyria, Genevostat is there. So many new molecules are coming. All are gene therapy molecules.
So, are they available in India and are they affordable? Because this spinal muscular and all, we always hear in, it's always in news, no?
Sir, that is true, but it will change, because Risdiplam, it was 6.2 lakhs 2 months back, but now NACO is an Indian made is 11,500 per bottle. So naturally, make in India process, everything will come in India. So definitely it will be more affordable. Now it is very, very expensive, including Luxturna, as you know,
Yes.
it is very, very expensive. And gene therapy for spinal muscular atrophy is 16 crores. It is very expensive. Everything is expensive. Gene therapies are very, very expensive. But rest of the molecules are reasonably affordable, molecular targets. But definitely it will come to the Indian market in a reasonable price in next 3 to 5 years. Because we are having rare disease program that is called the NPRD policy, National Policy for Rare Disease, which is we are also designated as a center of excellence for rare disease, where all these things are there. So Government of India is also CDSCO, everybody is easily giving more of a, what you can say, rapid permission for these type of drugs. And Indian make is having a lot of benefits are there. So definitely probably this Luxturna also will be coming in Indian market by the Indian company at the earliest. Thank you.
Now I request Sasraman sir to hand over a memento to Dr. Shankar as a token of our appreciation.
We have got, so I didn't want to encroach upon, now we have got 2-3 minutes more, and we will take a couple of questions. Maybe a question and we will see how time is.
Thank you, sir, for the very enlightening talk. Sometimes when we come across children who have undergone genetic testing, the report comes as mutation of unknown significance. And they might have a strabismus or something, which is not reported when we search in the net. So my question is there any site like OMIM where we could go for a more credible evidence? Second is how to do genetic counseling for this patient. Unknown significance, should we insist on another?
Correct. So this variant of unknown significance is a major issue even now throughout the world. Because there we don't have, that means we don't have sufficient literature to say that that variant is disease causing. So practically speaking, we cannot do prenatal diagnosis based on that. We cannot confirm the disease based on the variant of unknown significance. So for a practical clinical sense, if it is a variant of unknown significance, you don't have to consider it is a disease causing. Only thing is after 1 or 2 years, you can do the reanalysis of the variant so that sometimes it may change to pathogenic. Because how it is being to variant of significance to pathogenic, when multiple people put the same entry into the ClinVar or various databases, then this 10 people have told that same strabismus is due to this gene, this gene, this gene, then it will become the likely pathogenic. So that is very difficult, very crucial situation, very difficult to counsel that situation. And the databases, there are databases, you can use the ClinVar, I think ClinVar. ClinVar is these are all NCB free databases. Paid databases are there, I don't think clinician that is useful. You can go to the NCB same date database where PubMed, OMIM, everything is there. There you can put, you can say ClinVar, CLINVAR. ClinVar is the normal variant database. You can see in that variant database what is the things. Then there another called the Franklin is there, which will help you to change whether it is any change of this variant has occurred.
Thank you, sir.
So thanks to all the panelists, to our guest speaker Shankar, and all the delegates for your patient hearing. Thank you.